Welcome to the Cold Steel Surgical Podcast with your hosts Amir Farouk and Chad Ball. We've had the absolute privilege of chatting with some amazing Canadian as well as international guests over the past year. While the topics have been broad in range, whether clinical, social, or political, our aims for the podcast continue to remain the same. We hope to inspire discussion, creativity, scholarly research, and career development in all Canadian surgeons. We hope you enjoy our second season as we continue to highlight some incredible guests, deliver detailed masterclass sessions on a myriad of clinical topics, and introduce some fresh new features such as debate and companion formats. We hope you relish the podcast as much as we do.
In this episode, we were lucky enough to be joined by Dr. Alison Laws. Dr. Laws is a breast surgical oncologist at Brigham and Women's Hospital in Boston, Massachusetts. We delve deep into topics that many trainees struggle with: neoadjuvant therapy for breast cancer, indications for axillary lymph node dissections in 2020, and an approach to recurrent breast cancer. Finally, Dr. Laws shared some deep insights with us on how her experience as a patient shaped her perspective as a surgeon. Dr. Laws, thank you so much for joining us on the Cold Steel podcast today.
Thank you for having me.
Can you tell us a little bit about where you grew up and what your training pathway was?
Yeah, for sure. So I grew up in Markham, Ontario, which is a small suburb of Toronto. And then I did my Bachelor of Science at the University of British Columbia in Vancouver. I've moved around a lot. So I then went back to Ontario to medical school at McMaster University. And then in terms of my surgical training, I did my general surgery residency at the University of Calgary. And then I went on to do a breast surgical oncology fellowship, which I've just finished up this summer. And I did that in Boston, Massachusetts. And it was a combined training program between Massachusetts General Hospital and Brigham and Women's Hospital. And then currently I've accepted a breast surgical oncology position at Brigham and Women's Hospital. So I've just started on there as junior faculty. And then I'm also concurrently over the next 2 years doing a Master's of Public Health through the Harvard T.H School of Public Health. And so I'm kind of doing that concurrently with my first couple of years of practice.
I remember, you weren't, if I recall correctly, you weren't completely sold initially on doing general surgery. Like I think you had initially planned on potentially doing obstetrics and gynecology. Is that correct?
Yeah, that's correct.
What made you change directions and become their loss and our gain?
Yeah, it's a good question. I mean, I enjoyed sort of the clinical and technical aspects of both fields. And I actually, I had done a bunch of obstetrics and gynecology rotations early on, and I liked it. And so I sort of just committed as a medical student. I was at McMaster, so it's a 3-year program, and you feel a little bit of pressure to sort of commit early and make sure that you're planning your clerkship, appropriately so that you're competitive for the match, et cetera, et cetera. And I had planned a couple of general surgery electives just kind of later on because I felt that they would, give my profile a little bit of diversity and give me a little bit of exposure to a, semi-related field, surgical field operating in the abdomen. And then I basically loved those 4 weeks of general surgery. And I think a lot of it was the people. I felt like it was just sort of I felt that the general surgeons I worked with, at least for those 4 weeks, I just felt like I fit in really well with them. I liked, it was a really kind of collaborative group. General surgeons were fun. I felt that it was kind of a better fit from that perspective. And I also really, loved the clinical side of things and the technical side of things. And it kind of met all of the other criteria that I was looking for. But yeah, it really was the people that kind of changed my mind.
I think that rings true for a lot of us. What advice do you have? Obviously you had done most of your electives in a different specialty and then you wanted to apply to general surgery. How did you sort of manage that during your interview process, during CARMs, and what advice do you have to applicants who maybe change their mind late in the game, especially for three-year medical students?
Yeah. I mean, it was very stressful. And, I think I was just tried to be as honest as possible. So, I made sure to address that fact in my personal letter. I made sure to address it in the interviews. What else? I mean, I think I really tried to make it very clear to the general surgery people that I had worked with as a medical student that, I really truly had changed my mind, and really kind of tried to seek out their support as well, and made sure that they were kind of aware of that fact so that they could potentially address that in reference letters, and, make sure that the messaging was really consistent. But I think there's no question that, it's a challenge when you change late in the game. And, I probably had fewer interviews as a result, and, you kind of just have to roll with it and do your best. But I have absolutely zero regrets. And I think it's also really important that, if you do change your mind, you need to know yourself, and you need to know what the right path is for you. And, I was willing to accept that if it didn't work out, the match didn't work out, then I would try again the following year. But I really wanted to sort of commit to the path that I felt was right for me in the long term.
I think that's excellent advice. You finished residency in Calgary, and then obviously went on to do breast oncological surgery in Boston. I'm sure you could have done anything, got any fellowship that you wanted. So why breast surgery, and what was it about that that drew you to the field?
Yeah, I think, for me, I actually kind of gained and developed an interest in breast through clinical research initially. So I got sort of hooked in with Mei-Lin Kwan, who's one of the breast surgeons in Calgary, for an early research project in my first year of residency. And she became a mentor of mine, both from a clinical and research perspective. And as I sort of developed a research profile in the breast umbrella, I think I just kind of naturally developed a clinical interest alongside that. I had always had an interest in women's health. That was part of my draw to obstetrics and gynecology. And so I think that piece sort of fit nicely with breast. And as I moved through residency, it really became clear to me that I was looking for a field where I could not only sort of develop a clinical expertise in a single area, but also have a concurrent sort of research career. And I felt that breast really offered that opportunity. That was also then kind of a motivator for pursuing the fellowship as well.
I do want to make one comment about having watched you do research as a resident. I think you're one of the few people that actually listened to advice from people who had gone before us, and you picked a topic that you were able to generate a fairly big sort of database on, and then ask that database multiple different kinds of questions, and it turned out to be a very kind of productive line of research. Can you sort of comment on that? And was that a deliberate sort of choice, or and is that something that you sort of recommend for people looking to do research in residency?
Yeah, I definitely think so. I'm trying to think now. Essentially, almost all of the projects that I did as a resident did come from a single database that I basically built with chart review sort of in my first and second year of residency. And so I think in the end, I had 4 publications out of that kind of single data set. And there's lots of questions that really could be continued to ask from that. So yeah, I think it worked out very well. I think, that's not always, I guess the field that you're interested in and the question that you're interested in doesn't always lend itself well to that. And I think really what made me productive was the fact that I was truly interested in in sort of the questions that I was asking and the field of research that I was pursuing. And I think that is probably the most important thing above all, is that you pick something that you're actually interested in. But certainly if you can sort of curate a data set that is, complete and comprehensive and then allows you to ask multiple questions, that certainly worked for me. And I think it's a great strategy as a resident.
we wanted to take the opportunity to ask you some burning questions about breast cancer and breast surgery. As you will remember, we texted you many times while we were studying for our Royal College exams. I don't know if it's too early for me to talk about the Royal College exam. I still have a little PTSD, too fresh. But there definitely breast cancer and breast in general can be a confusing topic for residents. And so we wanted to take the opportunity to just pick your brain about a few of the topics that I think consistently kind of come up as challenging topics. And I think the first one I wanted to start with is the sort of the neoadjuvant scenario. So, the scenario that they often will paint for you on an exam is that you'll let's say you'll get a 50-year-old female who comes in with a new diagnosis of a breast cancer and has a palpable clinical node or a positive clinical node on FNA. How do you go about sorting out who needs a neoadjuvant treatment, and how do you sort of approach that in your head?
Yeah, definitely. A bit of a controversial topic and a confusing topic. I think, the way that I was taught to think about this, in residency and then further in fellowship, I think there's kind of one bucket that are patients with triple negative and HER2 positive disease. And then there's another bucket that are patients with hormone receptor positive HER2 negative disease. And I think, it's important to think about those patients a little bit differently. So, for patients with triple negative and HER2 positive disease, we know that the majority of those patients are going to receive chemotherapy as part of their treatment. And there's two important trials that I think are nice to be aware about as a surgeon that have come out in the last couple of years that look at our ability to tailor a patient's adjuvant systemic therapy based on their response to a standard neoadjuvant regimen. And so the two trials that I'm referencing, one is the CREATE-X trial and one is the CATHERINE trial. And in both of these trials, so CREATE-X was HER2 negative patients, CATHERINE was HER2 positive patients. People received standard neoadjuvant chemotherapy. Then if they had any residual disease in the breast or the axilla, so patients who did not have an overall PCR, they were then eligible to be randomized to either standard adjuvant treatment or a tailored therapy. So in CREATE-X, that involved capecitabine, and in CATHERINE, that involved TDM1 instead of adjuvant trastuzumab. And they showed a survival benefit for people, for patients in the intervention arm. And I think these two trials have really solidified the value from a systemic therapy perspective of using a neoadjuvant approach. And these have been certainly two very practice-changing papers, at least at my institution, whereby really sort of all patients with triple negative disease are strongly considered for neoadjuvant chemotherapy. And in HER2 positive, those with stage 2 and above disease, so either node positive disease or tumors greater than 2 centimeters in size, again, are kind of strongly considered for a neoadjuvant approach. We also know that in these subtypes, those patients are the most likely to get potential local regional therapy benefits. So these are the patients whose tumors really shrink down and become amenable to breast conserving surgery if they were large to begin with. Or these are the patients who are most likely to have an axillary PCR and potentially be able to avoid an axillary lymph node dissection. So that would apply to the patient that you've referenced in your case, right? A node positive patient. If they have triple negative disease, they have probably about a 50% chance of being able to avoid an axillary lymph node dissection with neoadjuvant chemotherapy. And with HER2 positive disease, it's even higher, in the 60 to 80% range. So, it's become that there's really a lot of advantages to a neoadjuvant approach. And certainly I think anybody with triple negative or HER2 positive disease, it's not unreasonable to consider a multidisciplinary consultation and really be thinking about any of these patients as potentially benefiting from neoadjuvant chemotherapy. For patients with hormone receptor positive HER2 negative disease, it's a little murkier because, particularly in the era of genomic assays, what we're learning is that, both a fairly substantial subset of both node negative or node positive patients may not actually get a lot of benefit from chemotherapy. And so chemotherapy may not necessarily be a part of their treatment. And you don't want to be overcommitting people to neoadjuvant chemotherapy and potentially getting in this scenario where you're over-treating patients. So I think we have to be particularly thoughtful in this group. That being said, a patient who's node positive at presentation, really their only chance to avoid an axillary lymph node dissection is with a neoadjuvant approach. But we need to recognize that depending on sort of the features, the biology of their disease, you can look at the tumor grade, you can look at the histology. If you have a genomic assay available, you can look at that even off of a core biopsy. And depending on their biology, you can sort of get a sense of what type of response they're going to have. In some cases, the likelihood of an axillary PCR is really small, and you might actually benefit from just an upfront surgery approach. Really get a sense of the stage of the disease so that your medical oncologist then has all the information they need to make their adjuvant therapy decisions. I think, again, in a clinically node positive, hormone receptor positive, HER2 negative patient, I certainly think a multidisciplinary consultation and consideration for neoadjuvant chemotherapy is reasonable. But I think we do need to be a little bit more thoughtful about sort of committing patients too early and over-treating patients with that approach.
There are a couple of things I think to just highlight again what you're saying. So I think that where it gets confusing, and you've made that distinction very beautifully, is that just because they're node positive doesn't necessarily mean that they will benefit from getting chemotherapy. But for an exam purpose, it probably makes sense to at least say that you're going to send them to a multidisciplinary clinic to actually have everyone's input. But that you have to be thoughtful a little bit about who's going to actually get neoadjuvant therapy.
Yeah, for sure. And I think, in the real life setting, I think it's also really helpful to know sort of what your local medical oncology practices are to some extent. And I found this even doing electives as a resident. I did a few breast electives in Toronto and Vancouver. And then, of course, I had experience in Calgary. The sort of local institutional practice patterns do differ a little bit between those places. And so I think sort of being mindful of that and having a good relationship with your medical oncology colleagues and knowing, if you can start to learn what types of things they'll consider a good indication versus not a good indication, and, educating yourself as a surgeon, I think is really helpful.
Can you talk a little bit about what neoadjuvant chemotherapy involves? Like, what is the regimen that's typically used, sort of the mechanics, like how many months does that work out to be? And even the logistics, like, do you always clip the primary tumor in the axillary node if they do have a positive axilla? Can you talk a little bit about what's done at your institution?
Yeah. So again, variable depending on the subtype. So for patients with HER2 positive disease, of course, their neoadjuvant therapy should involve some kind of HER2 directed therapy. So kind of the standard therapy would be trastuzumab. Plus or minus, there's a second agent that is sometimes added called pertuzumab, depending sort of on the extent of disease and the disease features. The chemotherapy backbone that's given along with the HER2-directed targeted therapy varies a little bit by institution. So, answering the question about kind of the typical regimen is a little bit tricky. I think the kind of probably what's good to know is just that there's multiple different regimens, some that are a little bit more chemotherapy intensive than others. The other approach is that sometimes they'll start with sort of a more, mini chemotherapy regimen, assess the tumor response. So maybe give something like just Taxol, Herceptin, assess response. If the patient's not having a great response, then they might add AC, towards the end of the regimen. So it is sort of a little bit of a moving target. For triple negative disease or hormone receptor positive HER2 negative disease, typically, I'd say the most standard regimen is ACT, so anthracycline, cyclophosphamide, and Taxol. Again, the kind of exact timing and dosing varies a little bit, but in general, there are injections that are given, every 1 or sometimes every 2 weeks, depending on the medication. And it's usually sort of a 3 to 4 month course of treatment in total. So in terms of kind of surgical planning in a patient who's going to receive neoadjuvant chemotherapy, making sure that you've really worked up the extent of disease in the breast and the axilla at the outset is important. Certainly any sites of disease that are suspicious on whatever breast imaging you've chosen should be biopsied, and anything that is a biopsy-proven cancer should be clipped. The practice of clipping lymph nodes is a little bit controversial, a little bit institution-specific. At Dana-Farber, we do routinely clip lymph nodes that are, any lymph node that's biopsied gets a clip. And then if that lymph node turns out to be positive, and if the patient is then, has a good response and becomes clinically node negative by physical exam after their treatment, then they are, in most cases, offered a sentinel lymph node biopsy as well as a targeted excision of that clipped node. And we actually localize those with a radioactive seed. So that node gets excised based on the localization with the seed, and then we perform a sentinel lymph node biopsy with dual tracer concurrently.
You talked a little bit about genomic profiling. Can you talk a little bit about that? Is that something that's pretty standard at Dana-Farber and BWH, or is that something that you're using selectively? And in those cases where if you're using it selectively, who are you using it in?
Yeah. So I would say, for patients who are clinically node negative and have estrogen receptor positive, HER2 negative disease, the majority of those patients are getting a genomic assay to help guide their adjuvant chemotherapy at Dana-Farber. And they follow the TAILOR-X trial that suggested the patients with a low or intermediate, we use the oncotype here, the 21 gene recurrent score. So patients with a low or intermediate score are typically not felt to have a significant benefit from adjuvant chemotherapy, whereas patients with a high recurrence score, again, kind of generalizing, would typically be considered for adjuvant chemotherapy. There are other clinical features that can trump that. So I wouldn't say, we make decisions based on the genomic assay exclusively, but it's an important piece, I think, in guiding the decision-making. We don't have the same sort of level 1 evidence for the use of the recurrent score in patients with node positive disease. However, there is sort of mounting evidence to suggest that it probably can be used in that setting as well. And there's an ongoing clinical trial that will answer that question called RX-Ponder, but we're not expecting results for still a few years. So it is being used selectively in node positive patients as well. We're also starting to use it sometimes to help make neoadjuvant treatment decisions as well. So patients, again, with estrogen receptor positive, HER2 negative disease, if it's a patient who has a large tumor and, we're thinking about neoadjuvant therapy maybe to help facilitate breast conservation, or if it's a patient with node positive disease, and we're thinking about, can we downstage the axilla to avoid an axe dissection? Sometimes we'll use an oncotype to help guide the approach of whether a neoadjuvant chemotherapy versus neoadjuvant endocrine therapy may be more appropriate. And particularly if your goal is breast conservation, neoadjuvant endocrine therapy can often help you achieve the downstaging that you need and can potentially help with this issue of not sort of over-treating people by giving them chemotherapy early on when, depending on the final features of the tumor at time of surgery, they may not actually need that therapy. So that's, I would say, a little bit more novel use of the genomic assay that, I suspect will become more popular, but I think that's sort of something that's evolving.
Are you talking about Oncotype DX, or is this a different genomic assay you're talking about?
Yeah, Oncotype DX, or sort of the 21 gene recurrence scores, the other sort of more generic name for it. So that's the one that we use. And I mean, there's lots of data coming out about some of these other assays, PAM50 and et cetera. But the one that I'm most familiar with, just because we use it at Dana-Farber, is the...
Obviously, the way you're thinking about these issues is at a fairly high level, fairly sophisticated kind of way where you're really trying to think about what the evidence is behind the various treatment options and the patient in front of you. And obviously, the multidisciplinary kind of discussion about these things is super important. In the rectal cancer world, that also seems to be a big move where, especially now that we're having things like total neoadjuvant therapy, that's becoming increasingly important. Do you think that we're going to get to this point where, all breast cancers need to be discussed at a multidisciplinary meeting, or do you think that would be too overwhelming? Like, what are your thoughts on that? Like, do you think breast cancer is going to become an increasingly specialized, kind of rarefied specialty that you really can't practice unless you're doing a high volume of it?
Yeah, I think, I think, so, I mean, I can tell you the model at Dana-Farber is that all new breast cancers are seen in a multidisciplinary setting. So all new breast cancers are scheduled both with the breast surgeon and with a medical oncologist at the first visit. And it was similar at Mass General, except that their multidisciplinary setting at the first visit always involved a visit with the breast surgeon and with the radiation oncologist, actually. And then they would see the medical oncologist as well at that visit if it was sort of a patient that the surgeon had flagged as, potentially needing some neoadjuvant systemic therapy. So that is the model that we use. I don't know that I feel that that's absolutely necessary for every breast cancer patient. I mean, the reality is there's still a lot of these run-of-the-mill, postmenopausal, ER positive, HER2 negative, node negative, screen detected cancers where, upfront surgery is still very much the standard. And I think most surgeons are pretty comfortable in that sphere. How much those patients really gain from a multidisciplinary visit at the first meeting, I'm not sure it's totally necessary. And I agree. I mean, I think there's some risk there of sort of overwhelming patients with too much information at the first visit, right? Like in some instances, you're meeting with 3 providers. Maybe you have genetic testing that day. Like it's a lot, I think, for patients to take in. But certainly in triple negative and HER2 positive disease, and, I kind of gave my bias earlier. I think that, I think a multidisciplinary visit for any patient with that subtype is quite reasonable. And I do think that, the care is becoming more and more nuanced. And so, even as a provider, having the opportunity to meet in a multidisciplinary setting and just be able to discuss the case with your colleague and kind of bounce ideas off of each other and come up with a plan that's sort of somewhat laid out from the outset, I think is nice. I mean, it gives me comfort as a provider, and I think it does make sense for some patients.
Yeah, I think that's an underemphasized point of the multidisciplinary conferences is that how helpful it is for you as a surgeon to actually be able to talk about it with other clinicians and make sure you're doing sort of the right thing. Okay, so I think that was a fantastic overview of sort of an approach to neoadjuvant therapy. I think another related topic that gets people all twisted up is sort of the indications in 2020 for an axillary lymph node dissection. And I really think, honestly, it's probably more helpful to think of it in that way. Like, who are the people that actually still should be getting an axillary lymph node dissection as opposed to the other way around? Because it's just such a rare occurrence. And I think, most general surgery residents probably don't see very many of these through their career. So break it down for me. How do you sort of think about who is getting an axillary lymph node dissection in 2020?
Yeah. So, I mean, I think there's kind of 2 branch points that I think about. I think the first is whether we're talking about upfront surgery setting versus post-neoadjuvant chemotherapy setting, because the algorithm kind of really is different for those 2 spheres. So if we think about upfront surgery setting first, then I think your next branch point is sort of, is the patient clinically node negative or are they clinically node positive? And that's defined by your physical exam as well as by any imaging identified abnormal lymph nodes that are then biopsied and found to have disease. Like that patient I would put in the clinically node positive bucket. And so if they're clinically node positive and we're talking about upfront surgery, that patient needs an axillary lymph node dissection. So that's a pretty easy one. If we're clinically node negative and upfront surgery, then most of those patients are eligible for a sentinel lymph node biopsy. That's usually your first step. And if the sentinel node is negative, then that's easy. They don't need an axillary dissection. It's when the sentinel lymph node is positive, this bucket is kind of, I think, the most confusing one. And it's because you sort of need to know what are the clinical trials where there's been investigation of, it's safe to omit an axillary lymph node dissection under these criteria. And I think, the three trials, I guess, to know about would be the ACAZOG Z11 trial, the AMROS trial, and then the IBCSG 2301. So the last trial that I referenced, basically, if patients have only micrometastatic disease in the sentinel node, they don't need an axillary lymph node dissection. If patients have had breast-conserving surgery and had a T1 to 2 disease to begin with, and then they have 1 or 2 positive sentinel nodes, that's basically the criteria for ACAZOG Z11, and those patients don't need an axillary lymph node dissection. If they have 3 or more positive nodes, sentinel nodes, then they don't meet those criteria. Or if they had T3 or T4 disease to start with, then they don't meet those criteria and would need a node dissection. The AMROS trial was very similar, except that it also included patients with mastectomy. However, in that trial, patients received axillary radiation. So in that case, if you're talking about a mastectomy patient, again, T1 to 2 disease with only 1 or 2 positive sentinel nodes, they don't necessarily need an axillary lymph node dissection as long as they are candidates for post-mastectomy radiation, where the axilla will be radiated. So that is kind of the confusing bucket, I think, and you just kind of have to commit those criteria to memory, for the exam and in real life. If we're talking about post-neoadjuvant chemotherapy, I almost think this is a little bit easier. So, people who were clinically node negative prior to their treatment and who remain clinically node negative after treatment would have a sentinel lymph node biopsy. And if it's positive, any number of nodes, any volume of disease, they need an axillary lymph node dissection. And basically the same goes for patients who were clinically node positive at the outset. So if they are now have converted to clinically node negative and you do the sentinel lymph node biopsy and remove the clipped node, again, any number of positive nodes, any volume of disease, they need an ax dissection. And then the final category are patients, I guess, who are clinically node positive, get their neoadjuvant chemotherapy, and are still clinically node positive. And really, I kind of define that as still a positive physical exam. Then those patients need an ax dissection. We typically, don't offer a sentinel lymph node biopsy if you can still feel abnormal disease in the axilla. So, unfortunately, there's just not a really super easy way to break it down, but that is kind of the branch points that I think about. And hopefully that gives people somewhat of an approach.
The one thing we didn't mention that I think it's just important to clarify is that inflammatory breast cancer, those people are going to have to be referred for neoadjuvant chemotherapy, and then all of those people will get an axillary node dissection, right?
Yeah, that's correct. So that's really, none of the trials looking at the safety, or sorry, I shouldn't say the safety, none of the trials looking at the feasibility and false negative rates of sentinel lymph node biopsy after neoadjuvant chemotherapy in a node positive patient have included inflammatory breast cancer. So that is really still an area where, yes, a triple therapy approach. So neoadjuvant chemotherapy followed by a modified radical mastectomy followed by post-mastectomy radiation is still the standard of care.
The one thing I was hoping you could also do is to briefly go over your high-level kind of thought process on and approach to the axillary dissection, because I think, again, this is something that's going to become an increasingly rare thing for general surgery residents to do. So sort of in, 10 steps or less, sort of if you could summarize how you approach ax dissection.
Yeah. So, this was definitely an area where fellowship training was useful because, I agree. I think I had only done sort of a handful of axillary node dissections, and actually most of the ones I had done as a resident were for melanoma. So, general approach. So I think, I usually make an incision sort of along the anterior axillary hairline. I use sort of a curvilinear incision. The reality is you actually don't need a really large incision. I think the key is that you then get down and widely excise the clavipectoral fascia. And I remember that's something that I learned sort of memorizing as a resident to talk about this surgery, but until you've done a few, you don't really realize what the value of that is. And so I think, real life advice is that, that widely excising the clavipectoral fascia is really what gets you good visualization of the axilla. There are then a couple of, surgical approaches. I prefer sort of a medial to lateral approach. So I like to start by identifying the pectoralis major muscle, and I sort of widely, dissect along that muscle. So I've really nicely exposed it. I then follow it down so that I've exposed pec minor. And I'm really kind of down on the chest wall and have started to loosen up that tissue, really got into that axillary fat. I then work my way superiorly and identify the axillary vein. And this can often really just be done with blunt dissection, particularly if you've kind of started that medial dissection. Just blunt dissection with your finger on a sponge or a sponge stick, whatever instrument you like. Once you've identified the axillary vein, I usually leave about a centimeter. So I work sort of about a centimeter inferior to the vein and just work my way along medial to lateral. There will often be some crossing branches that need to be ligated. Work my way all the way along, really until I've identified the latissimus. And then I come down the latissimus. So this is, now we're kind of at the lateral side, and I fully dissect along the latissimus. So that I've now kind of really defined my medial, my superior, and my lateral border. And then at this point, I go back to the medial, to the chest wall. And again, really using exclusively blunt dissection. If you've kind of gotten down to the chest wall, you can sweep all of that axillary tissue off of the chest wall until you've identified your long thoracic. Confirm that you've identified it. I do like to do this with the patients not paralyzed. So that I can be really confident that I've found my nerves. And then I basically work my way now sort of superiorly. You're now working, I think that I'm kind of working towards the patient's back. So you're kind of working straight down until you've identified subscap. And you're just peeling that tissue sort of inferiorly and off of the subscapularis. And here is where you'll ultimately come across your thoracodorsal bundle. Obviously that, you want to preserve that. And I continue to clear the axillary tissue, even lateral to the thoracodorsal, really all the way to the lat, which I've already identified. So this is actually the pretty easy part of the operation. You're just kind of peeling everything within those borders that you've already created. And, the inferior aspect of the axilla is kind of a nebulous border. There's not an obvious anatomic landmark, but really, your lat and your chest wall almost kind of start to converge. And that's how you know you've gotten to the inferior aspect of the axilla. And I, typically this all comes out kind of in one block. That's really level one. Often you've kind of got some of level two, but I then do, make a note to really make sure that I felt with my finger sort of under the pec minor. And if, particularly if there's anything gross that I can feel sort of, dissect out any additional level two nodes that I've missed in my initial dissection.
That was a brilliant description. What do you think are the big pitfalls that, or technical tips that you have for getting yourself out of trouble when doing this?
Yeah, I think that early exposure is really key. So that, sort of what I was harping on, I guess, about that clavipectoral fascia. And then I think, for me, I just find it really helpful. The pec is a really consistent, easy landmark, and that's why I like to start there. I think sometimes you can get a little bit lost in the axilla. And I think just really, systematically identifying those three landmarks, the pec, the axillary vein, and the lat, will really keep you oriented. And then, the nerves from there are actually, the nerves, the long thoracic nerve and the thoracodorsal bundle from there, are pretty easy to identify.
The last topic that I'm going to pester you about or ask you about is on recurrent disease, because I think that was something that we also struggled with a lot with studying for our exam. They'll give you different sort of scenarios the isolated axillary recurrence, the isolated supraclavicular recurrence. Maybe we can start with sort of your general approach. You have a patient who has previously had surgery for breast cancer and now comes back in with, let's say, a isolated supraclavicular node. How do you approach that patient?
Mm-hmm. Yeah, so I remember a lot of the scenarios you worry about for the exam, clinically in real life are actually really rare. But nonetheless, I think, anybody with local, regional, recurrent disease, it's reasonable to first sort of stop, take your time. I do believe in distant staging for all of these patients. I think NCCN does recommend that. So really restaging, biopsying suspicious things, really identifying the extent of disease, because there is a significant proportion of patients who will present with concurrent distant metastatic recurrences at the time of a local regional recurrence. And, you don't want to miss that. I think local or regional recurrences is really an area where multidisciplinary review is critical. I think here is definitely an area where involving medical oncology, involving radiation oncology, all of your subsequent treatment decisions are largely dependent on what previous treatment the patient has had. And so, having the colleagues who have administered those therapies previously involved and really understanding sort of where this patient stands is critical. The isolated supraclavicular recurrence, I think, again, it's really dependent. Like if a patient has already had regional nodal radiation, then they're not necessarily eligible for that again. And so in that case, you'd be thinking more about systemic therapy. I think if they haven't had prior regional nodal radiation, then, radiation first approach is often the way that we'll go, although it does depend a little bit on the extent of disease, because, radiation is really most effective for small volume disease. So, again, a little bit dependent on the presentation. I think it's important to know for the exam that, we don't surgically resect supraclavicular disease. That is not typical therapy. So really sort of radiation or systemic therapy is your first step. The same goes for internal mammary nodes. That's not really thought of as surgically resectable disease. Isolated axillary recurrences, if it's an operable lesion, then typically the first step would be an axillary lymph node dissection, and then followed by, potentially axillary radiation, again, depending on what the patients had previously, plus or minus systemic therapy, depending on what the patients had previously and the extent of the recurrence. And then for locally recurrent disease, I guess would be sort of the last scenario. Here, again, their previous surgical therapy is really important. So a patient who's had previously breast conserving surgery and has a local recurrence, the standard therapy would be a mastectomy. And typically we do try to restage the axilla. This is a little bit of a data-free zone, but in a patient who's previously had a sentinel lymph node biopsy, our practice certainly is to try a repeat sentinel node biopsy, and it actually will map the majority of times. In patients, alternatively, who have already had an axillary lymph node dissection, we do not routinely restage the axilla in those patients unless there's something grossly abnormal on their exam. And then if patients have had a prior mastectomy and have a chest wall or a skin recurrence, again, if it's operable disease, then typically an excision to negative margin would be your first step. And then sort of adjuvant radiation and systemic therapy, depending on all of those other factors.
I guess one of the things that we struggled with was sort of the sequencing sometimes of what therapy you'd get, particularly for the supraclavicular lymph node recurrence. It seemed like there was some difference depending on what resources you'd read about whether to chemo first versus radiation first. Does that really matter, or is that sort of just an institution dependent type of issue?
Yeah, I think, to be honest, I feel like it's a little bit outside of my area of expertise. My understanding is that, depending on the bulk of disease, the radiation oncologist can help determine whether they feel that their radiation therapy can effectively can effectively treat that volume, or if the patient may benefit from some cytoreduction from systemic therapy such that the radiation therapy can then be more effective. So that, I think, is where the sequencing piece does become a question. And I think, again, outside of my area of expertise, but, involving those two colleagues, I think that's why it's so critical.
It's interesting to listen to you guys talk about not doing that many axillary lymph node dissections in residency, because I'm not that old, I don't think, but I certainly remember doing them sort of every day on general surgical rotations. It's interesting to see how far things have come. And it's always fascinating to listen to that, because it seems, in terms of progress and treatment progress and philosophy, to change within breast oncology, maybe even at a pace greater, or certainly a sustained pace that's greater than most other fields. One of the things I remember, Dr. Laws, was being told very early in my residency, which again is a little bit ago now, that soon one day breast oncologic management would be entirely non-operative. That's clearly not the case now. Mm-hmm. What's your vision or your belief in terms of if that'll ever happen, and maybe what that will look like in another 15 years from now?
Yeah, it's a really interesting thought. Again, I think there's real sort of differences amongst breast cancer subtypes with this question. And so, particularly patients with triple negative or HER2 positive disease who are, more and more commonly treated with their neoadjuvant systemic therapy, which is usually chemotherapy up front. Chemotherapy has gotten so good that it does really have this ability to melt away disease in a significant proportion of patients. And we're seeing that sort of even at great percentages now, and there's better systemic therapy coming down the pipeline. We just had sort of some early data about immunotherapy in the neoadjuvant setting for triple negative breast cancer presented at ASCO this year, and we're seeing even greater rates of a complete pathologic response with that therapy. And so I have to believe that the systemic therapy is just going to get better and better. And, in the setting where it's done first, I could see that. I could see that we are eventually going to get to a part where surgery may not have a role in all patients with breast cancer. There's already been a lot of interest in this, in these subtypes in particular. And unfortunately, thus far, there's not any one imaging modality that seems to be able to predict a PCR with enough reliability. There's also, after that was kind of determined, there's now been more recent efforts looking at, can we do multiple core biopsies of the tumor bed? And can that be, have a reasonable enough false negative rate that we can identify patients who don't need surgery? And unfortunately, those early efforts have, not suggested that that's the case, and we're not quite there yet. But certainly in those subtypes in particular, I can see that coming. In the hormone receptor positive HER2 negative disease, I'm not as sure. I think if anything, the movement in the systemic therapy world has been, trying to pull back a little bit on how many patients we're giving chemotherapy to, as we've talked about today, genomic assays have really helped us to identify a large subset of women who don't get a lot of benefit from chemotherapy and who have excellent long-term outcomes with endocrine therapy alone. And, even if we were to think about moving endocrine therapy to the neoadjuvant setting, we know that endocrine therapy doesn't really melt away disease the way that chemotherapy does. And so my gut is that in those patients, there's always going to be a role for surgery. But who knows? I mean, I totally agree. It's amazing. So Amir and I were talking earlier that just, things have changed in breast since I wrote my exam, a year ago. It's just the pace of change is extremely rapid. And I think, I think it could go a many number of ways.
Yeah, it's so true. It's really remarkable. And it's probably a good model of not only envy, but really something we should all aim to in other subspecialty diseases. It's awesome. Mm-hmm. If you don't mind, Ali, we wanted to touch on just a short list of things. Again, more about you, and move on from the importance of your breast comments. with regard to oncologic care. Both you and Amir have spent time in Boston at various parts, and as we heard, you continue to be there right now, and maybe forever. Who knows? Hey, but I'm curious. Everybody I've ever known who's gone to do some segment of training in Boston, from really undergraduate all the way through medical school and fellowship training and staffdom, has absolutely loved that experience. So first to you, and then also to Amir, what is it about Boston that is so enriching and so unique and so awesome?
Yeah, it's very true. I mean, I feel the same way about my training and now my my position here. I think there are really a large concentration of sort of the thought leaders in the field of breast cancer concentrated at Brigham and Women's and Dana-Farber, and getting to work alongside those people in sort of the clinical care of your patients on a day-to-day basis, and then also in your academic efforts. You just can't help but learn from them. I mean, there's so much knowledge. And not only is there so much knowledge, but it's an environment where they really promote education, and they really are focused on, the more senior colleagues mentoring the junior people in the department, and the amount of sort of time and focus and attention, I think, that's given to making sure that everybody is learning and moving forward. And kind of this idea of lifelong learning is really just epitomized in the group, certainly the breast oncology group. And so I think I have been so grateful for that. I mean, just, the amount of time that people dedicate to sort of mentoring you and making sure that you're progressing as a clinician and as an academic. There's a really strong focus on that. And that is, makes all the difference as a trainee or as a junior faculty.
Yeah, that's so well said. What? It's interesting. One of my best friends, who's a neurosurgeon in the U.S. Now, did a PhD at the University of Alberta, and he was a pretty good heavyweight. I mean, his first 2 papers were published in Science, and his third in Nature. And he went down to Harvard and did a postdoc down there, and then did med school, and then left. And I asked him the same question. I said, "What's the difference between U of A, in the biochemistry world, which was superb, and Boston?" He said, "Well, the difference is you can walk down the hall and talk to 3 people that have won a Nobel Prize on that topic." And I was just like, "Oh my God, that is truly amazing." And I wish we could all experience that.
I'd just echo what both of you are saying. I think it's just the ability to have rich conversations with people from many different backgrounds who really care about what they're doing and really believe that they can make a difference and change things. That it's a very intoxicating kind of experience, and it's really enjoyable. Ali, we wanted to talk to you a little bit about one of the topics that we've talked about on the show before, which is the concept of regret. So Tim Pollack, who's obviously a heavyweight in surgery down at OSU, has written a lot about this topic of regret. And this is particularly important in breast cancer, where there's a lot of different factors that patients have to think about, including cosmesis, but also, oncologic considerations like recurrence. How do you approach these very challenging discussions in clinic with patients?
Yeah, it's definitely very applicable. I think this comes up a lot when you're counseling patients about breast conserving surgery versus mastectomy. I think this is probably even more relevant when patients are thinking about a contralateral prophylactic mastectomy. And I think, we're fortunate in breast that there's actually been a lot of interest in incorporating patient-reported outcomes into some of the, research efforts that have been done in this area. And so we actually do have some reasonable data that we can talk to patients about. And I do explicitly address that with patients, for patients thinking about bilateral mastectomies. There's a really nice position statement that's been put out by ASBrS that sort of summarizes some of that data. And, I tell patients that so like I say, I talk quite explicitly. So I first sort of focus on my oncologic recommendations and what I think, is good treatment options for the patient from an oncologic perspective. And then I always turn the discussion to, what are the implications for you otherwise as a mastectomy or of a bilateral mastectomy? And we know, fortunately, not a lot of patients express significant regret about their decision, although there are probably somewhere in the range of 5 to 10% of patients who do regret whatever decision they make. But there are, about 25 to 35% of patients that, if they choose mastectomy, are unsatisfied with their outcome in some way. And I think patients don't appreciate that about a mastectomy. And when I say unsatisfied, that's, things like you've identified. So unhappy with the cosmetic result. What I think patients appreciate even less is the impact on their body image, their sexuality. And that's been, well documented in some of these studies that have asked patients. And, we have data from large numbers of people on this. And so I pretty explicitly talk about that with people. And I find if you've kind of given, the oncologic information and then some of this PRO data, I think from there patients do self-select a little bit. And I think, at the same time, I trust that most patients know themselves pretty well. And that's probably why we see, relatively low rates of true, regret with a decision. I think, I think people kind of self-select from there as to whether, these balancing of these oncologic considerations versus, these other real quality of life outcomes with more aggressive surgical treatments. But, some patients are more receptive than others. And so, the conversation is very different every time. And, sometimes I feel better about it at the end than other times. So I think it's still something that I'm sorting out, to be honest.
Well, that's well said, Alison. The last thing we wanted to talk to you about, and again, thank you for your time and your expertise and your candor. The last thing was about your experience, really on the other side of the knife or the table or the curtain or whatever terminology you'd like to use, but as a patient who underwent surgery. And I mean, I'll just point out for the listeners that we did clear this with you before, and we're really privileged that you're willing to talk about it. I guess my questions are sort of maybe threefold. The first is just broadly, what was that experience like in hindsight? I'm curious also how it may have altered or probably did alter your view of surgery and your development as a surgeon in general. And then I'm curious in particular about, for somebody like me, to be honest, who, I had a knee procedure done, but that's not saying a lot. Someone who has a more invasive or high risk procedure. What are some of the things that you think, we need to be cognizant of and improve upon as surgeons and physicians in general for the patient?
Yeah, it's very interesting. So I had this experience, it was a laparotomy, was my operation for a tumor, the urachal tumor that turned out to be benign, but there was some diagnostic uncertainty. And I was 20 years old. I was in third year university. So this was really sort of pre-medicine. And I'm very grateful, honestly, to have had that experience before having any exposure to the medical world, because I definitely think that it has given me insight, definitely insight into what it's like as a patient who's not kind of in it and who's, naive to the whole medical sphere. I think it was a stressful experience. I think it was stressful partly because of my other life circumstances. Like I was sort of in the middle of applying to medical school and in the middle of exams, and it all happened very quickly. I was living where I didn't have any family. And so, I think I have a definite appreciation for how sort of your other life context can shape the experience of having to go through a major operation and sort of prepare for it mentally, have it, recover from it, all of these things. It definitely shapes the way that I care for patients. And I think, it was interesting. I don't know that it largely influenced my decision to pursue surgery, but the fact that I did choose general surgery, I think it has kept the whole experience a little bit fresher in my mind than it otherwise may have been. And sometimes I'm surprised at the level of detail that I still remember about the whole experience. And I think, being in the surgical world and sort of becoming really attuned to all of these things on the other side has helped me to kind of remember and keep it fresh in my mind. I think, the way that it has shaped how I provide care, there's a couple of things. There's a couple of like key moments that I remember. One was the feeling of sort of entering the operating room. And, to be honest, I wasn't particularly afraid. I felt okay. I felt kind of mentally and emotionally ready pretty much until that moment where I was rolled into the operating room. And I remember like the whole environment just suddenly felt very foreign. I felt a lot of fear. You suddenly had people kind of touching every part of your body, right? Like people are putting things on your legs and your arms and your face, and lots of people are talking at you. And, I remember that being just very overwhelming. And so now as a surgeon, it's something that I actually talk to patients about in the pre-op therapy area. I sort of warn patients that, listen, when you get in the room, there's going to be a lot of bodies. You might hear a lot of talking. You're going to hear monitors. People are going to be putting things on your body. So, I don't know if that helps. Maybe that just makes people more worried. But I think, that was really surprising to me and kind of took me by surprise. And it's something that I do now communicate to patients ahead of time. I think it also has made me really cognizant about that period of time in the operating room. As a surgeon or a trainee or the nurse working in the room, it's kind of just another day in the office. And I think sometimes, there can be personal conversations, there can be laughter, there can be, it can be a little easy to just kind of not be laser focused on our professionalism. And I think those moments, I now really think about that and strive to kind of keep that as, try not to add any more overwhelming piece to that experience for patients. And, it's a short period of time between when they come in the room and when they're anesthetized. And I think really kind of controlling the environment and maintaining our professionalism during that time is really critical. And it's something that I think about, based on my own experience.
Having been on the other side of the table as well, too, I really wanted to echo one thing that you said about just realizing like how important this moment is to that person you have lying on the table. Like I felt exactly the same to you, which is interesting, even though I had a totally different operation. That I just didn't want anyone like laughing. Like now it's funny because I recognize that like when people are relaxed, that's actually a good sign. But I didn't want that when I was having my surgery. Like I just wanted people to be like totally focused on me and just really like treating me like I was, the most important person in the room. So it's just funny how these little things, when you become a patient, you really notice, and they're not necessarily the same things that you think matter to you as a surgeon, right? Like, as surgeons, we're thinking about recurrence and mortality and morbidity and these very hard outcomes, but it's like sometimes these very little things that really bother patients. How do you think that we can go about getting a better sense of what really matters to patients and trying to address those things just as much as the big things that we're always concerned about?
Yeah, it's a good question. So a good example of this, I guess, from my surgery was, remember in the preoperative consultation, he's talked to me about everything involved in the surgery, and I, whatever, kind of went through all the details, went through the expected recovery, and then he had me get up on the examination table and he examined me. And then while he was examining my abdomen, he kind of showed me like, okay, here's what your incision is going to look like. And, it was like umbilicus to suprapubic bone, basically. So it's a pretty big incision. And I remember like all of a sudden being like, oh my gosh, like, wow, this is real. Like, this is a big operation. And then I'm almost embarrassed to admit this, but then the second thing I thought about was, oh my gosh, like I'm going to have this huge scar. And, I had to have my umbilicus resected as part of this operation. And so then he's, telling me you're not going to have a belly button anymore. And, those things mattered to me at that point in my life. I was sort of like, oh, wow. Okay. So, what can I do to sort of make the scar heal well and make it look like normal if I wear a bathing suit and these kind of things. And I think about it now, and I'm sure, as the, urologic oncology surgeon, he's like, oh my goodness, this girl, cares more about her incision than anything else. But, he allowed me time for that narrative. And he listened and, he gave me a monocryl closure and, some other little things. And I think that really helped build rapport. And I really appreciated him for that. And I still do. And so I think we have to respect, what our patients tell us and, when possible, try to accommodate that and be aware of the fact that they may be worried about things that we're not, aren't necessarily front and center in our mind. But I bet most people who go through surgery have a story like that of, something that they were a bit fixated on that the surgeon sort of wasn't. And, within reason, I think we want to allow patients, time to express that and sort of accommodate when able.
You've been listening to Cold Steel, the official podcast of the Canadian Journal of Surgery. If you've liked what you've been listening to, please leave us a review on iTunes. We'd love to hear your comments and feedback, so feel free to email us at podcast.cjs@gmail.com or connect with us on Twitter @CanJSurge. Thanks again.